Welcome to continuing coverage of the World Healthcare Congress 2012. In the studio right now is Dr. Douglas Moeller, and we like to speak with him every year about the latest and the greatest in the healthcare sector. And this year I have to read from my notes that you are working on value-based reimbursement with a focus on bundled payment. Now that's a mouthful, so I need you to break it down for me.
So bundled payment has two components. It has a clinical managed result for outcomes and a bundled price or lump sum price. That may be a lump sum payment or a lump sum reconciliation where you settle up after all of the services have been provided to see what happened.
Well, now who determines the bundled payment?
So it's important to start with an episode definition so that the stakeholders, the physicians, the hospital, the health plans, all know what services are included in the bundle and what services might be outside the bundle. So it may be that a pacemaker includes everything except the pacemaker unit, which is expensive on its own. And so that might be outside, but everything else of putting it in a pacemaker, one payment for the whole thing.
And why do you think that this is such a focus?
I think that same as it's not very helpful to buy a car by buying all the parts individually. It's better to have an agreement on, I'm going to get the whole thing and this is my price.
Okay.
And that there's a warranty or a follow-up period where all of the things of making sure that things went well for a knee replacement or whatever the intervention is, your gallbladder removal, that you're really better.
Is it still a work in progress in terms of determining the price for that unit
for the
versus
bundle,
the pieces for the bundle?
Absolutely.
And who's getting together to talk about that?
Well,
and deciding.
Let me back up a step and say that there are five parts of how we break this down. The first part is how do you set up a bundle? In other words, who should have which service is that front end, and that's what we have we use clear coverage as a solution to open that discussion. The second key piece is how do you actually bundle claims? And so as a claim stream comes in, the health plan can actually recognize which services or claim lines are part of that bundle. The third part of it is the care coordination of what are the providers doing to actually do things differently and more efficiently. The fourth component of analytics is how do we keep track of what's happening so that in terms of a dashboard for what's occurring with a particular patient, including alerts if certain things don't happen that should happen, as well as variances that are infections or complications that are preventable. And then the fifth component and final component is what's your network management of what providers are in, how am I growing my program and so forth. Do I start in a single region and then grow to more regions or just add bundles? And so that's all part of setting up a program. How you price it then depends on what's in, what's out, and how the parties understand what they all need to do.
And is there a move towards more understanding? Is there widespread adoption at this point?
Oh, I think there's been tremendous interest, and in addition to medical home, which is sort of a episode at a primary care level, there's a tremendous interest from specialty groups to start to put this together. There's a couple of things that are important to occur, and that the health plan needs to be ready to do it in terms of their information systems, and the providers need to be able to do it in terms of are they packaging that before they send an episode request or after.
Are we seeing this in play already?
We are.
And at what level?
So bundle payments are not a new idea. DRGs are a bundle payment for a single provider. DRG is a diagnosis-related group that Medicare started in 1983 as payment for inpatient hospital services. And there's been variations about that, but never included everybody. Certain organ transplant programs that have been around for the last 15 years have had a single price and a single outcome because you could get your arms around that and everybody goes, I need a bone marrow transplant, I'm going to go to Pittsburgh.
Right.
Or I need a kidney transplant and I'm going to go to a certain place, and we know what that costs. And so there are precedents for putting this together.
And are you putting some bundles on top of the list more than others in terms of speed and getting the bundled pricing?
So that's a great question. There's two categories of bundles in a sense. The event-triggered bundles, like a knee replacement or something that has a specific date where something happens. And then there are time-triggered bundles, and that's where medical management, like congestive heart failure or chronic lung disease or diabetes, where you provide all of somebody's care for a year, comes into play. The tricky part of medical management is the levels of care, of how intense, what's the acuity of illness of a particular patient. And for, say, congestive heart failure, it might make sense to have 4 different levels, and we need to be very clear who's in which level and how does the payment vary. And so we've been focused on event-based bundles to get started, understanding that the best advantage is going to come when we can actually do medical management.
Is this all a good thing?
I think it is a good thing. I don't always get optimistic as I get farther and farther into a project, but on this, I really think it's a little bit intricate, but quite doable. And once we get inside of this and get people to operating on this, I think it's going to be better.
Well, how do you see it improving quality of care?
The quality of care is that if we have people be accountable for preventable complications and so forth, where everybody's involved, everybody starts looking after what everybody else is doing in a much more coherent way. I was actually at the hospital where that was one of the bundled payment projects in the 90s that CMS hosted for bypass graft. And they sat down, the surgeons, the cardiologists, and the hospital sat down, re-looked at the entire care process. And before they were done, they took 10% out of the total cost and 2 days off of the average length of stay from 7 days to 5 days. That was a huge improvement in quality.
And that was a long time ago.
And that was a couple years ago. Now, that I hear that trial mentioned occasionally. That's when I perked up that there's an opportunity here to do a better job.
Well, terrific, Dr. Moeller. I really look forward to getting more information and an update next year.
I'll be back.
We'll be here. Thank you so much.
You are welcome.
I'm Abel Jung. Thanks a lot for watching.